Dr. Bender is one of our pulmonary critical care attendings based at St. Joseph's Hospital. Speaking on this topic, thank you.
So I just found out that the person ahead of me was not here, and so for the first time in my life, being early actually paid off. So my wife's out of town, so she actually won't believe that I was early, so if someone could just... I'm going to talk about the role of non-invasive ventilation and high-flow oxygen systems and their role in potentially avoiding intubation. Non-invasive ventilation is something I think most of the room is fairly familiar with, but I think the high-flow oxygen systems are something that are gaining increased prominence, but are something folks aren't fully aware of. So, I have no financial disclosures, and the overall objectives here is just to kind of review the basic principles and physiology of non-invasive ventilation and high-flow oxygen systems, understand the role both of these entities can play in managing acute respiratory failure, and in particular the role they play in various types of acute respiratory failure, and then look at some of the evidence surrounding the question of, okay, should we use a high-flow oxygen system here instead of non-invasive ventilation? So to start with, non-invasive ventilation, again, something where the room is mostly familiar with, but it's the application of respiratory support via a sealed face mask or other interface without the need for endotracheal intubation. And classically now we have continuous positive airway pressure and then bi-level modes as well. And these can be delivered by kind of specifically designed devices or just connecting a mask and some tubing up to an ICU ventilator. And if I can figure this out. There we go. So, these are the variety of masks that we've all kind of tortured patients with in the hospital. The full face masks, the nasal mask. What have I done? And even the mythical helmet mask, which we actually have at St. Joseph's, but I've actually never really seen used. And non-invasive ventilation, not surprisingly, is associated with a number of benefits. There's a relative decrease in its technical difficulty. It requires minimal, if any, sedation. It avoids any of the complications associated with endotracheal intubation, which, as much as we do it, is still a high-risk procedure. There is some data suggesting a decreased morbidity and mortality associated with it, and then there's decreased cost associated with its use as well, particularly when you factor in the entity or the fact that it will avoid intubating someone. The physiological benefits of non-invasive ventilation are pretty well known, and I didn't want to turn this into a physiology talk, so this is just a nice summary table. It doesn't project that well, but it's a nice summary table from a review a couple of years ago in respiratory care in 2009, Khaled et al., and it just kind of highlights some of the physiological benefits of non-invasive ventilation, the first of which being a decrease in the work of breathing, just decreasing inspiratory effort and offloading the diaphragm. And there's evidence in the literature of up to 60% reduction in work of breathing and decrease in electromyogram work of the diaphragm. At the same time, it has an effect on the breathing pattern of patients, decreasing their sensation of dyspnea and decreasing their respiratory frequency. There's good evidence that it increases dynamic lung compliance, particularly in patients with COPD, along with those who have a kind of a restrictive chest wall process. And then the cardiovascular function is perhaps the best known of these, particularly its reduction in left ventricular afterload, which you can trace to its effects on folks with cardiogenic pulmonary edema. And then lastly, not surprisingly, its effects on gas exchange, improving the partial pressures of oxygen, decreasing the partial pressures of carbon dioxide, so just facilitating good gas exchange. And so just to dig a little bit deeper into it, this is just an interesting paper from the mid-2000s out of France in the Blue Journal that looked at the physiological effects of non-invasive ventilation in folks with acute lung injury. So they all had P-DAF ratios less than 300. And what we see here on the axis over here is their reports of improvement of their dyspnea. So being obviously more positive improvements in their dyspnea. And as you took these folks with evidence of acute lung injury and gave them varying degrees of non-invasive ventilation, they reported an improvement in their dyspnea score. So simple CPAP generated a degree of positive improvement, while in this particular case, BiPAP with an IPAP of 15 and an EPAP of 5 demonstrated the greatest improvement in their dyspnea. At the same time, this is a bit busy slide, but as you just kind of look at the trend of all of the columns here, this is some of the physiological parameters that they followed through the use of both esophageal and gastric balloons. But across the board, the utilization of non-invasive ventilation resulted in an improvement in their work of breathing, again with bilevel demonstrating more of an improvement than just CPAP, but in both of these entities demonstrated improvement over what the patient was initially presenting with. So again, non-invasive ventilation, CPAP and BiPAP is fairly well known in the critical care arena. The use of a high flow oxygen systems, particularly high flow nasal cannulas, is not as, I would say, as well known. So just to kind of review briefly, it was initially developed in neonatal medicine and introduced as an alternative to CPAP in that patient population to treat neonatal distress syndrome. And it was recently in more prevalent use recently in the adult population to deliver oxygenated gas to adults. And systems currently exist with the ability to deliver adequately heated and humidified gas that flows up to 60 liters per minute, which is a pretty robust delivery system. This is kind of your classic diagram of what a high flow nasal cannula system looks like. And you have a flow meter and an air oxygen blender, which you set your FiO2 with, and that generates your flow rates. You have an active humidifier down here at the bottom that humidifies your moving oxygen up to temperatures of 38 degrees Celsius. And then your heated inspiratory circuit, and then loose fitting nasal prongs. And then usually some sort of tie that, again, is usually falling off their face every time you see them. So these systems are, like I said, increasingly prevalent. The cost of these systems varies. A brief email to one of the directors of RT up at Emory St. Joe's cited right around $3,000 for the cost of this. In the literature, prices I've seen ranging from $2,600 up to $3,500. So the physiological effects of high flow nasal cannulas are fairly well known, and perhaps the main one that everyone likes to tout is kind of the washout of the anatomical dead space that you get with this system. You basically build up a reservoir of high flow oxygen in the oral cavity and the pharynx, and at the same time you get a decreased breathing frequency while maintaining constant minute ventilation and PCO2s, and so you get a washout of your anatomical dead space. At the same time, you can get there is evidence that these systems will provide a degree of PEEP. If you make sure the patient's mouth is closed, the general rule of thumb is about 1 centimeter of water pressure for every 10 liters per minute that you're using. So seeing as standard flow rates when we start folks on this are 40 to 60 liters, you're looking at somewhere in the neighborhood of 4 to 6 centimeters of water pressure of PEEP in this population. And in both animal and human literature, it's been seen to be adequate to increase lung volumes and do some degree of recruitment of alveoli. One of the other nice physiological benefits to this entity is that in patients that are using non-high flow systems, their inspiratory flow rates tend to outpace the delivery device itself. And at the same time, masks tend to have, little holes and all that sort of stuff to prevent carbon dioxide rebreathing. So even though we say they're getting near 100% FiO2, particularly with a non-rebreather, they're actually not. With a high flow nasal cannula system, particularly if the patient's mouth is closed, your FiO2 delivery is consistent across the board. This is a nice study from the anesthesia literature from about 2011 or so, Ritchie et al., who basically measured hypopharyngeal oxygenation in patients using a high flow nasal cannula, and found that when folks had their mouth closed and they were at rest, the oxygen concentration measured in the hypopharynx was virtually the same as what was being delivered via the machine, which you're not going to see with some of the other non-high flow systems or less robust delivery systems. And lastly, inhaling kind of dry, cold oxygen provokes kind of upper airway dryness, and there is evidence that suggests it impairs mucociliary functions. And so, this can obviously just be uncomfortable, having a bone dry nose and a bone dry mouth. But there is some evidence that it can increase your risk of aspiration and gastric distension. The ability to kind of provide robust humidification to this kind of high flow rates reduces the discomfort associated with this and can help with airway clearance and comfort. So, I think having kind of looked at some of the basic principles, it's not unreasonable to now kind of look at, acute or patients with degrees of acute respiratory failure and what some of the evidence says in this patient population. And I think just kind of right off the bat, the first one that immediately comes to mind and is probably well known to all of us in here are folks with acute exacerbations of COPD. And not unsurprisingly, and I think everyone kind of knows this at this stage of the game, non-invasive ventilation is the ventilatory tool of choice for these folks when they present. And kind of one of the hallmark studies that looked at this was in the Lancet back in 2000 by Plant et al. And they took 236 patients and split them right down the middle, and half of them received standard therapy alone, inhaled bronchodilators, steroids, standard supplemental oxygen, and the other half received all of that plus non-invasive ventilation. And the use of non-invasive ventilation showed a significant reduction in the need for intubation. There was a 27% failure in the standard group versus only 15% in the non-invasive group. And the in-hospital mortality was also reduced in this non-invasive group, and not surprisingly, a more rapid improvement in acid-base status, improvement in their respiratory rate, and their duration of breathlessness. And this has been echoed by the Cochrane group as well. They took a look at about 14 randomized controlled trials back in 2004 and found a relative risk ratio of 0.41 favoring non-invasive ventilation as compared to standard care. And when you look at a number needed to treat, this translates into a number needed to treat of only 4. So pretty significant data supporting the use of non-invasive ventilation in folks with COPD exacerbations and preventing intubation. And the same can be found when you actually look at mortality as well. The literature across the board is very supportive of non-invasive ventilation, as we can see down here. And the number needed to treat in this particular instance, based on the Cochrane data, is only 10. So, cardiogenic pulmonary edema, again, a very well-known entity that all of us face, particularly in the medical and the cardiac critically ill. And non-invasive ventilation across the board has been shown to be favorable in this population as well, and to stave off intubation in this group as well. This is a meta-analysis from JAMA in the mid-2000s from Massip et al., which again, very similar to that seen with the acute exacerbation of COPD population. Non-invasive ventilation showed a significant benefit on mortality, and also when you looked at the need to intubate. So getting folks on non-invasive early leads to more favorable outcomes. Unquestionably. And so, not unsurprisingly, in these two patient populations, when we see them, it's almost Pavlovian at this point to get them on some non-invasive ventilation in addition to the rest of the care, whether it's diuresis or NEB steroids, plus or minus antibiotics. Now, what's interesting is when you dig a little bit deeper and you kind of move away from those two kind of hallmark populations, the beneficial effects of non-invasive ventilation is not as clear. Particularly in folks with pure acute hypoxemic respiratory failure. In some literature published in the Journal of Intensive Care Medicine back in 2006, Demouillet et al. and kind of did a survey of about 70 French ICUs, and when they kind of looked at everything they were studying, there was about a failure rate of about 54% of non-invasive ventilation in patients with acute hypoxemic respiratory failure. And when they did some univariate analysis of this data, they found that the presence of hypoxemia with P to Fs less than 200 was one of the factors associated with this propensity towards failing non-invasive and requiring intubation. And at the same time, they also noted that the mere element of failure that resulted in intubation was more likely to be associated with mortality. So merely slapping non-invasive ventilation on someone may worsen outcomes by just delaying intubation in someone who's going to fail anyways. And there's some literature actually going as far back as the early 90s that shows the use of non-invasive ventilation can result in an adverse workload on both nurses and respiratory therapists. And I think all of us have kind of struggled with the patient at the bedside who just can't get the mask comfortably on his face, has a leak that is blowing things off the wall because it's not on their face, and all of that sort of stuff. So there is evidence that suggests maybe non-invasive ventilation is not the cure-all for everyone with acute respiratory insufficiency. And so obviously then you begin to wonder if using high-flow nasal cannula systems would potentially offer some benefit in this population. And there is decent literature that suggests this. Park and his group in respiratory care in 2011 looked at postoperative cardiac surgery patients with mild to moderate acute hypoxemic respiratory failure, and this definition was a little squirrely, but they found that high-flow nasal cannula patients Using that in patients resulted in a less likely need to escalate to non-invasive ventilation, and they ended up with fewer desaturations than those treated with standard high-flow venti masks and non-rebreathers, and also had improved comfort and less reporting of dyspnea. Roca et al. In the transplant literature looked at a retrospective analysis of transplant patients and found that the use of high-flow nasal cannula at the time of admission to the ICU for folks with acute hypoxemic failure was associated with a decreased risk of intubation. One of the better known studies probably among this group is from the Blue Journal back in 2014, Maggiore et al. They looked at the use of high-flow nasal oxygen and compared that to oxygen being supplied via a venti mask. And then the FiO2 was adjusted to both groups. The population they studied it in were patients who were just extubated. So both groups had kind of mild oxygenation defects and a degree of respiratory distress, but equivocally, the high-flow nasal oxygen group ended up having better oxygenation, had a lower respiratory rate, reported improved comfort with the interface, improved levels of dryness, so their mucosa were less dry, and by extension, they were more comfortable. And this also resulted in a lower intubation rate. Now, one of the caveats to this study was that there was some concern about how the venti masks were being used, and actually there was some underestimation of the P to F ratios due to the inclusion of room air with the venti mask and it not being fully and appropriately fitted. But again, there was a trend towards a favorable profile with the high-flow cannula device with this patient population. And so perhaps, probably one of the most well-known trials, I think, at this point that looked at, a patient population with acute hypoxemic respiratory failure was the FLORALI trial, high-flow oxygen therapy for the resuscitation of patients with acute lung injury. And this was a randomized controlled trial that looked at 310 ICU patients with hypoxemic respiratory failure, so PaO2s less than 300. And they looked at the rate of endotracheal intubation among kind of this three group of patients that were randomized to high-flow oxygen via the large bore nasal cannula device, standard oxygen therapy, or folks on non-invasive ventilation. And one of the nice things about this trial was that they got rid of the patients or excluded the patients who had any sort of underlying chronic respiratory disease, including folks with COPD. The rate of endotracheal intubation did not differ significantly among the three groups in this trial. As you can see here, the non-invasive ventilation, standard oxygen, and high-flow oxygen, all non-significant difference between them when it came to who ended up intubated. Now, what's interesting is the high-flow oxygen group had a significant increase of number of ventilator-free days, as well as a reduced 90-day mortality when you compared it with the standard oxygen group. Now, this was done kind of in a post-hoc analysis. At the same time, high-flow oxygen, not surprisingly, this is one of the trends that you'll see when you review all of this literature, the high-flow oxygen was associated with less respiratory discomfort and a reduction in dyspnea as well. So patients felt better while using it. Now, there are some caveats to this. The study itself was underpowered, and it's, actually, in truth, a negative trial, considering that the main outcome variable, the intubation rate, really didn't differ significantly among the three treatment arms. And when you do some digging into the methods, the patients randomized to the non-invasive arm actually received non-invasive for only 8 hours a day on the first 2 consecutive days, and then ended up getting high-flow oxygen after that for around 16 hours a day. And when you look at some of the patient characteristics, there was a greater septic shock population in the non-invasive group as well. So it's certainly possible that they were a sicker population, which may have skewed things a little bit, particularly in the secondary analyses. So one of the other, I think, interesting points to consider with this is when you look at folks who have been intubated, they're now extubated and they're struggling a little bit. We do know in folks that have COPD that extubating them to BiPAP, they tend to do a little bit better. But what about folks that either don't have COPD or maybe they're not going to be able to tolerate BiPAP due to just an intolerance of the device or claustrophobia or for one of the million other reasons that folks kind of struggle using the mask? Hernandez et al. Kind of looked at this question in a recent article in JAMA from late in the fall of 2016, and they looked at the use of high-flow oxygen in critically ill patients who are ready for planned extubation with at least one high risk factor for reintubation. And the high risk factors, I've kind of listed them all here. I know this is a busy slide, but when you kind of look at a lot of these high risk factors, age greater than 65 years, an Apache score greater than 12, BMIs over 30, difficult or prolonged weaning, more than one comorbidity. I mean, this is kind of the majority of the patients we take care of, at least in our MICUs. So I feel like this is a pretty applicable group. And they randomized these patients who are ready for extubation to high flow versus non-invasive in 24-hour kind of increments. And basically, high flow nasal cannula was non-inferior to non-invasive ventilation for preventing post-extubation respiratory failure. You know, an incidence of 27% in that group to a little under 40%. At the same time, it was not inferior for preventing re-intubation. Interestingly, when you looked at some of the secondary outcomes, the median post-randomization ICU length of stay was lower in the high-flow nasal cannula group compared to the non-invasive group by about a day. So that's a pretty, you know, when we think about the number of days we keep people in the unit, that's something that definitely perks your ears up. And then, you know, the adverse events, and these were very loosely categorized in the study, but included things that we do see with, you know, non-invasive use, you know, skin breakdown, mask intolerance. These adverse events were significantly greater in the non-invasive group, but like I said, somewhat poorly characterized. So, you know, to summarize then, I think, you know, non-invasive ventilation and high-flow oxygen systems, non-invasive ventilation's been around for a while. The majority of us know about it and know about its use. High-flow oxygen, I think, is becoming a little bit more vogue, and they both offer robust physiological profiles to assist in the respiratory management of patients. I think, you know, when you look at folks with COPD exacerbations and cardiogenic pulmonary edema, the use of non-invasive ventilation is a no-brainer in these folks based on the physiological profile of BiPAP, but also in what the literature shows us. But I think, you know, high-flow oxygen systems should increasingly be considered for use in the setting of acute hypoxemic respiratory failure, along in the post-extubation setting, you know, based on the data. And I think one of the other things that, again, gets, you know, is a secondary outcome in a lot of these studies, but I think plays a large role is the degree of comfort that patients experience with this. When you're taking someone who's in the throes of dyspnea, acute respiratory failure is already uncomfortable and, you know, as we know, a little bit loopy, and you add something that they're actually able to tolerate as opposed to some sort of robust mask over their face. I think it warrants, based on that, some increased use and consideration for use. So I can take any questions if there are some.